Hi, I'm Dr. Jeyabalan from CVSKL Hospital. Today, I'm just going to give a short talk on the various dialysis modality available for patients with acute kidney failure. In particularly, I want to concentrate most on CRRT or Continuous Renal Replacement Therapy. So, if what does CRRT means? CRRT, the word CRRT, there are many types of CRRT, CVVH, CAVH, CAVHD. So what do they mean? The word C at the beginning refers to continuous. That means it's a continuous process done over 24, 48 hours of continuous dialysis. The second letter is either an A or V. The A refers, if it's A means it's an arterial, AV means arteriovenous. That means we get access from the artery and returned by the vein. If it's a VV, which is most commonly used, means we get access of blood from the veins and return to the veins, which normally to a temporary dialysis catheter. And the second letter, the third letter, hemofiltration, H refers to hemofiltration, which means it's a convective method. I will explain further what convection means. Or HD means hemodialysis, which means it uses a diffusive method. And HDF means is a combination of both convective and diffusive methods. That means hemodiafiltration. And all of these things are done basically through vascular access catheters. Okay, so what are the major renal replacement techniques available to our patients, especially in ICU when they need dialysis? One is intermittent hemodialysis using the standard hemodialysis machine, usually for 3-4 hours dialysis. Number two is continuous technique, CRRT, which is mainly will be veno-veno in this setting. And the third, there's a hybrid techniques, which is basically called SLED or sustained low efficiency dialysis, which is a hybrid between intermittent dialysis as well as continuous therapies. So intermittent hemodialysis, it's the most easiest to do, which is using a standard hemodialysis machine, usually dialyzed for 3-4 hours. The main problem with intermittent hemodialysis in our ICU settings will be hemodynamic instability, because you've got to do a rather intensive form of dialysis, fluid removal within a short period, 4 hours. It requires quite a bit of stress on the cardiovascular system, and many patients in the ICUs have low blood pressures, in shock, cardiogenic shock, septic shock. So if they are hemodynamically unstable, intermittent hemodialysis can be problematic. The other thing about intermittent hemodialysis is that there's less flexibility in adjusting the prescription because the patient's needs in the ICU changes throughout the day. So maybe the patient is okay in the morning, nighttime needs some blood, needs some fluid removal, whereas the dialysis has already been done for that day in the morning. So there's less flexibility in adjusting the prescription. Whereas when we do the continuous therapy is going ongoing, so we can always adjust the fluid removal, etc., according to the patient's need. And the third problem is with intermittent hemodialysis is you need some form of water treatment system. Usually we use a portable RO system, a reverse osmosis system. CRRT, the continuous renal replacement therapies, the main advantage of that is they are less stressful on the hemodynamics of a patient, especially patients in shock. The CRRT's techniques do not affect the blood pressure as much as intermittent hemodialysis. The other advantage of CRRTs is that we can change our dialysis prescription according to the patient's needs. So if the patient needs extra fluids later, then we can extract more fluids later because it's an ongoing process. In addition, we often use CRRT from what you call a renal dose to a septic dose. There are some studies, some evidence that taking out higher amounts of solutes can remove inflammatory mediators and therefore may play a role in reducing systemic inflammatory reactions. In addition, CRRTs do not need any water purifying system because it's a standalone bags that we use for the fluids. The main advantage of intermittent hemodialysis is that it's cheap, it's easy set up, and the other advantage of intermittent hemodialysis is that we don't have to worry too much about drug removal because it's only for 4 hours. And in addition, because it's a short period, intermittent hemodialysis, we don't run the risk of clotting the system because it's only 4 hours. Whereas the CRRT is more expensive, you need a more sophisticated equipment, and because of the continuous therapy, there's a possibility that important solutes, drugs, may be removed because of the continuous nature of the dialysis. And because it's continuous, a lot of electrolytes, the good stuff can also get removed because of the long duration of CVVH done. And in addition, usually some form of anticoagulation is required because flow rates are very slow, continuous, so they tend to clot. And finally, compared to intermittent hemodialysis, CRRT is a bit more labor intensive, take a lot more time from the nurses, and often the nurses have to attend to the machine when it gives problems, etc. In addition, we also use this machine, CVVH machines, we can use it for high volume infiltration into setting of sepsis, as well as a plasma pheresis in conditions like myasthenia gravis, Guillain-Barré, SLE, etc. So, and even the thrombotic thrombocytopenic purpura, we can use a CRRT machine as a plasma pheresis exchange machine. There's another form of intermittent hemodialysis, we call it sequential ultrafiltration. Again, sequential ultrafiltration, what it means is we are using the hemodialysis machine, but only for the purpose of fluid removal. Example, in people with congestive cardiac failure who are resistant to diuretics, they are overloaded, you can use sequential ultrafiltration whereby you only remove water. Since there's no solute removal in sequential ultrafiltration, the fluid equilibrates between the vascular compartment and interstitium more rapidly, and therefore doesn't disturb the hemodynamics as much as hemodialysis does. So, but fluid removal ultrafiltration can only be done when the main concern is fluid, CCF, fluid overload, pulmonary edema. If you have acidosis or uremia, etc., then you cannot do sequential ultrafiltration. What about SCUF? SCUF is slow continuous ultrafiltration, which is actually same like ultrafiltration using the hemodialysis, sequential ultrafiltration, but using the CVVH machine. So it's similar, but except that the fluid removal is done more gently. So you remove about 100 ml per hour, 200 ml per hour, but over a 24 or 48 hour period. So again, it's mainly to maintain fluid balance. There's no significant convective clearance, so therefore no replacement fluid is required, but it's not going to address issues like acidosis, hyperkalemia, uremia, etc. Again, purely for fluid removal. If we do it slowly, then we do using a CVH machine, we call it SCUF. Okay, what about SLED? SLED is the best of both worlds. It's a slow dialysis, a low blood flow and dialysis flow rates, run over 8 to 12 hours. Most standard hemodialysis machines can be programmed for SLED. There's less need for anticoagulation as compared to CVVH, but it gives you a better blood pressure control in terms of stability of blood pressure than intermittent hemodialysis. And because the period is limited, about 8 to 12 hours, so there's dialysis-free time available, which can be used to administer drugs as well as do certain procedures. Because compared to CVH, you have about 12 to 20 hours, 16 hours where you don't do any dialysis. Okay, in the CVH, in CRRTs, there are many forms. What is CAVH? CAVH is basically hardly done. In CAVH, the lines are inserted into the artery as well as the vein. So what drives the filtration is actually the patient's blood pressure. So CAVH, you do not need any particular machines, but because it's a patient's blood pressure that drives filtration. So it's hardly ever used nowadays because most hospitals use machines. CVVH is much more easier to use and does not involve an arterial puncture. So what's the difference between hemodialysis and hemofiltration? Hemodialysis basically the method of removal of solutes is by diffusion, because you run a dialysate in the dialysate chamber, and the dialysate chamber contains less toxins, urea, whereas there's higher concentrations of urea and toxins in the blood. By diffusion, the urea moves in from the higher concentration to lower concentration. So it's by a method of diffusion. Whereas hemofiltration, which means CVVH as opposed to CVHD, the method of solute removal is by convection, whereby you apply a high hydrostatic pressure to push water across the membrane, and because of the solvent drag, the water drags solvents together with it. So the method of removal of solutes and toxins are by a solvent drag by pushing water through using hydrostatic pressure. So there's no dialysate flowing across in the dialysate chamber in hemofiltration. In hemodiafiltration, basically you do both a convection, you use a hydrostatic pressure and push the toxins across, and you run a dialysate and you get a diffusive. So you're trying to combine both together. Okay, so this is again the same thing the diagram shows. Basically, again, hemodialysis is basically solutes moving from higher concentration to lower concentration, whereas hemofiltration, a positive hydrostatic pressure, pushes water across a semi-permeable membrane, which is your dialyzer, and because of the hydrostatic pressure, the water goes into the other compartment and dragging the poisons together. So for hemofiltration, you need to take out large amounts of water to get significant solute removal. That's why in hemofiltration, we need to give replacement fluid to the patient, otherwise the patient will go into hypovolemia. And replacement fluids, there are special replacement fluids. Some hospitals still use peritoneal dialysis liquids as replacement fluids, but that should not be done in the modern era. Okay, this is the same thing. Again, the difference between hemodialysis and hemofiltration. One is solute by convection, the other one is by diffusion. And the other consideration when we do CRRT is whether we replace the fluid post-dialyzer or pre-dialyzer. With a post-dialyzer replacement solution, the advantage is that when we replace the fluids, it's replaced after the dialyzer, which means the chances of clotting the dialyzer is higher, but it gives you better clearance. So when we are worried about clotting, we always replace the fluid pre-dialyzer. When we are worried about solid clearance, we do a post-dilution replacement. So what's the difference between hemofiltration and hemodialysis? In theory, hemodialysis is better at removing small molecules. Hemofiltration supposed to remove larger molecules better. But in real life, no studies have shown one to be superior to the other in a convincing manner. So as you can see in this graph, hemodialysis, molecules less than 1,000 are cleared very well. But as the molecule size gets bigger and bigger, the clearance drops. Whereas for hemofiltration, the small molecule clearance is average, but it's maintained up to about 10,000. It's almost like the same clearance of a natural kidney, except it's a bit lower. But it clears larger molecules better with hemofiltration. So large molecules up to about the size of albumin can be cleared by hemofiltration, but not with hemodialysis. Hemodialysis normally clears about 1,000 kilodalton. What about CVVH, which is continuous veno high volume hemofiltration? The usual amount of the so-called renal dose is removing about 20 to 25 mils of kilogram of water per hour. But there's a thing called septic dose where we remove 60 to 100 mils per kilogram of water during CVVH. The theory behind that is at these doses, we are not just removing renal toxins, but also inflammatory substances like cytokines and other mediators of the SIRS syndromes in sepsis. So there are several studies, particularly from Italy and Australia, that has shown that CVVHVH, high volume infiltration, may actually improve hemodynamics in septic shock syndromes with acute renal failure. Okay, like I mentioned, ultrafiltration is mainly when we do it when we only want to remove fluids alone. And this is the system of the scarf. whereby you remove the fluids but over a slower period of longer period of time, and you do not replace them with any dialysate or replacement fluids. Okay, so again, the SLED basically mixes the benefits of CRRT with the economics of IHD. Normally with SLED, we do daily sessions of 6 to 12 hours. The blood flow rate will be low, around 150, low dialysis flow rate, using traditional dialysis machines. And you don't need too much anticoagulation as compared to CRRTs. And the dialysis fluid is actually done online by the machine itself, so you don't need separate dialysis bag, and it's got good cardiovascular stability compared to intermittent hemodialysis. Okay, so this slide says the same thing. Basically, it's a lower SLED compared to CRRT is cheaper to do, easier to perform, uses conventional equipment, and generally can be used just like CRRT in those with low blood pressures. Okay, this slide basically summarizes what I've already mentioned. So what do you do when you get a patient with acute kidney failure? So the first thing we do is, when do we start dialysis? If the patient has any life-threatening complications from acute renal failure. For example, the patient has got fluid overloaded, the patient has got acidosis, severe acidosis, hyperkalemia, patient is uremic and unconscious, then you start renal replacement therapy. If the patient has none of this with acute renal failure, then we optimize the hemodynamics, you ensure adequate intravascular volume repletion, correct hypotension, discontinue nephrotoxic drugs, and then you assess the patient. But if the AKI persists, again, if the acidosis starts developing or the potassium goes up, the fluid congestion does not respond to diuretics, then we consider renal replacement therapy. If the blood pressures are good, then you can do an intermittent hemodialysis. If the pressures are not good, then we recommend CRRTs. And which one is better? Till now, no studies have conclusively proven that intermittent hemodialysis, CVVH, CVHDF, any one of them gives you a survival benefit over the other. So right now, there is no evidence that one is superior to the other. You got to individualize according to your patients. And in terms of, is it any advantageous to start an early dialysis, that means initiate dialysis early? The answer is there's no studies that have proven that early initiation of dialysis makes a difference in this kind of patients. So you start the dialysis based on if there's any need arises. So there's no evidence if you start it early it makes any difference. Okay, in terms of one of the major issues with CRRTs is drug clearances, because when we do CRRT, it's done continuously over 24, 48 hours. So many drugs, including antibiotics, can be removed because most drugs are smaller than 500 daltons, and even hemodialysis machines can remove molecules up to 500 daltons. So, and with CRRT, because it's a continuous process, you can actually remove drugs up to 20,000 to 30,000 daltons. So this is a major problem with dialysis in ICU settings, because drug removal is always a big problem. Ideally, we should be able to monitor drug levels when we give these drugs, but unfortunately in Malaysia, many of these drugs we can't measure levels except for a few of them. So what that determines the drug removal? One will be the molecular size. The other one is whether the drug is water soluble or lipid soluble. If a drug is water soluble, it will be dialyzed out because water comes out together in the dialysis. Lipid soluble drugs won't be dialyzed out. And the other one is plasma protein binding. The drug is bound to protein, it will be less likely to be dialyzed out. If it's not bound to protein, then it's more likely to be dialyzed out. Okay, these are a list of some of the common drugs that are not dialyzed out because they are largely protein bound. So I think that is all my lecture for today. Thank you for your attention.